So let's get started. My disclosures were already given. The only thing that wasn't mentioned in my disclosure is that I do act as a medical expert for medical malpractice cases, and I do have a pediatric resuscitation device patent, but we're not going to be talking about pediatric resuscitation in this lecture. So when I'm having conversations about this question, TPA for acute ischemic stroke, when I'm talking about it, I like to start with common ground. And I believe that we do have common ground with our neurology colleagues. We both want our patients, because they're our patients, we share care with them. We see them, we're screening them, we're evaluating them, we're working them up. And we think they have a stroke. Well, we want them to get the best care possible. And we want it to be based on the best evidence. And so my position on thrombolysis for acute ischemic stroke is just that I'm skeptical. Now, that doesn't mean that I don't claim TPA does not work, but rather I'm just not convinced that it has a net patient-oriented outcome of benefit. And this is an important distinction in epistemology. So when we're going through the evidence, I'm not making the claim. And this is important because in science, and you are all doctors, you know that in science, the person making the claim has the burden of proof. And it's called a burden, not because it's easy, because it's hard to prove something. And we start in science with the null hypothesis, the null meaning no superiority. And so in compared to either control or a placebo. And then evidence needs to be presented to us to convince us to reject the null hypothesis and accept there is superiority to the claim about TPA and stroke having a net patient-oriented benefit. And if there is convincing evidence, we as scientists should reject the null and accept the claim. But if the evidence isn't strong enough, if it's not convincing enough, then we should accept the null hypothesis. And in this case, that TPA is not superior. So we're just accepting the null. And it's a logical fallacy to shift the burden of proof onto those who say, I'm not convinced. Those who say I'm not convinced don't have that burden of proof. They don't have to prove a negative or prove something is wrong. They just have to say, I'm not convinced with the evidence that's available to accept the claim. So let's take a look at the evidence for acute ischemic stroke analytics. There are 13 foundational trials on the issue. How many do you think there are out of 13 studies? Because we were doing this, we're doing this. How many do you think there are that show efficacy for the primary outcome out of that 13? Well, the answer is it all depends on how you count that. There's 2 trials. One randomized control trial under 3 hours, that's NNTs, and one trial from 3 to 4.5 hours, and that's ECAS-3. So you could count those 2 trials as showing efficacy. That means the other 11 did not show efficacy for lytics for their primary outcome. Or, and that's why there's a little asterisk there, if you consider the reanalysis that has been done on both NNTs and the reanalysis that's been done on ECAS-3, you get a nice round number of studies that show benefit in a randomized control setting for lytics and stroke. And that nice round number is 0. So there are 0 trials, you could claim, showing efficacy if you consider the reanalyses. So then the next thing to consider is the details. And if you look at the details, this is a very busy slide. And so I'm going to just color code it for you and say green good, red bad, yellow is meh. And these are the 13 foundational trials on lytics. Now, not all 13 trials used TPA, and I think that's an important point to make. But you have to have a good evidence that there is a reason to separate them from a patient-oriented benefit outcome. And we really don't have good data that says one lytic is superior for a patient-oriented benefit than another from the stroke literature, or for orders of magnitude bigger from the STEMI literature, that any lytic is superior for the patient-oriented outcome. You can get into disease-oriented outcomes, you can get into the harm side of things, but not for the patient-oriented outcomes and the primary outcomes that were recorded. And so then you have these 13 trials. The ones in red, 4 of them, 3 of those ones in red were stopped early because it was unethical to continue because of increased harm. 1 was stopped due to futility. And then there's those 2 that claim benefit, the NNTs and the ECAS3. Now this table, which I'll be providing to you, doesn't include the wake-up trials, the newer trials with the advanced perfusion imaging technology that we have. And that's because a lot of those trials had large vessel occlusions that would go on to be getting EVT. So let's just take a little brief look at TPA for acute ischemic stroke and the 2 positive trials. There was the NNTs trial in 1995, and maybe some of you weren't even born then, but that's when I graduated and started residency. So I graduated medical school in 95 and started residency just when NNTs was coming out. And it showed, and it was the first trial after a number of trials had failed to show superiority for TPA and stroke. And it had about 333 patients. Now this was reanalyzed by Hoffman and Schreiger, and they controlled for some of the baseline imbalances and said, actually, there isn't superiority to TPA. And said we were the analysis. So there's clearly some issues with regards to how robust that data is. Now, more recently, ECAS3 in a 3 to 4.5 hour window was reanalyzed by Brian Alper et al. And they too controlled for baseline differences observed in that one trial between the 3 and 4.5 hours that showed benefit for the primary outcome of TPA and acute ischemic stroke. And they found that they could not replicate the positive findings. The harm was still there, but they couldn't confirm the benefit. And I covered that on a podcast number 297. And a foundational aspect of good science is replication. Repeat it. Have someone else do the same experiment in a different patient cohort population to confirm what you've demonstrated. Can they repeat your experiment? Can they replicate your findings in another setting? And this has never been done for NNTs and ECAS3. It has been one and done. Now, there were other trials that didn't show benefit, but once they got a trial that did show benefit, that was the end of doing randomized control trials in those timeframes. So without replication studies, the data can still be meta-analyzed. You can still look at the existing data, even if it didn't have the same specific timeframes, because there were studies that went out to 6 hours that clearly included patients in under 3 hours and patients that were in 3 to 4.5 hours. So you can do a meta-analysis on this. And systematic reviews are usually put on the top of the hierarchy of evidence. And so that's why I have that triangle there. And that triangle puts systematic reviews and meta-analysis at the top. But the thing is, we have to be careful about something called GIGO. And that's garbage in, garbage out. A systematic review depends on the inclusion and exclusion criteria, in part for the studies being meta-analyzed. And there are 3 fairly recent systematic reviews on lytics and stroke. There's a Cochrane review, there's one published in the Lancet, and one published in EMA. And they came to slightly different interpretations of the available literature. So I'm going to make a, well, I guess I could give you what their interpretations are. Wardlaw, that's the Cochrane review, gave a fairly balanced conclusion about the potential benefits and potential harms, but they called for more trials. Emberson in the Lancet seemed more enthusiastic. They said, irrespective of the age of the patient or how bad the stroke was, and despite increased risk of fatal intracranial hemorrhages, during the first few days after treatment, alteplase significantly improves the overall odds of a good stroke outcome when delivered within 4.5 hours after onset of stroke, and an association with earlier treatment having bigger proportional benefits. And then the Donaldson systematic review in 2016, they were more conservative in their conclusions. They said there's clear evidence of increased mortality. So they put that up front. They don't put the benefit up front. They say the harm, that clearly there's evidence of early mortality, increased risk of symptomatic intracranial hemorrhage, but also there's improved functional outcome for patients with presumed acute ischemic stroke with thrombolysis. But the available data, they say, is unlikely to resolve the controversy regarding the use of it. And so they say, we need randomized control trials. We need more randomized control trials. And they say we need these trials urgently. So I want to say a word about conflicts of interest. Conflicts of interest don't make conclusions wrong, but it should make us more skeptical of the conclusions. And if I'm going to make a claim, I'm going to support it with evidence. So you shouldn't believe just what I say. You should be skeptical of what I say. So I brought a Cochrane review from 2019 by Hansen et al. To support my claim. Now, conflicts of interest are just another data point to consider when evaluating the validity of a publication. So the Cochrane review, looking specifically at financial conflicts of interest in systematic reviews, found that systematic reviews with financial conflicts of interest had more favorable conclusions. They tended to have lower methodologic quality than systematic reviews of interest. And they said, we should be skeptical. Oh, I like that. They say we should be skeptical of those systematic reviews with financial conflicts of interest, and we should interpret their evidence with caution. The Institute of Medicine 10 years ago actually came out with some guidelines for systematic reviews. So people who are publishing systematic reviews, generating the systematic reviews, they came up with some guidelines. And they said we should exclude people from systematic reviews with clear financial conflicts of interest, because it eliminates one of the potential biases that are in systematic reviews. So I have a visual here of what the conflicts of interest are on those 3 systematic reviews that I showed you. And so just visually, here are the declared conflicts of interest from each of these systematic reviews, the Cochrane review, the Lancet, and then the one by Donaldson and all. And I've only highlighted the financial conflicts of interest with Boehringer Ingelheim and Genentech, because they're the ones who make TPA. Now, to remind you, Wardlaw was fairly balanced. Emberson seemed more enthusiastic, and Donaldson was the more cautious, conservative skeptic, saying we can't really we can't answer the question we have. We really need more high quality randomized control trials to inform our position. And Donaldson had no financial conflicts of interest. And again, I'm going to reiterate, I want to be crystal clear on this. Conflicts of interest do not make the data or the interpretation of the data wrong. It just should make us more skeptical, as per the citation I provided on the previous slide. And also, Wardlaw and Emberson didn't seem to follow the Institute of Medicine's 2011 guidelines with regards to financial conflicts of interest. Talked about systematic reviews. What about the guidelines for TPA? Guidelines should guide our care. They shouldn't dictate our care. And in fact, many guidelines actually have disclaimers recognizing these limitations and say, hey, don't use these as a standard of care. And despite the claim, there's been this big push about we should get with the guidelines. But nobody ever says, how much do we need to get with the guidelines? Do we need to be concordant 50% of the time, 70% of the time, 100% of the time? What's the right amount? Where does the clinical judgment come in? If it's just an algorithm that we follow, why am I there? Why do they need me to apply my clinical judgment and my gestalt to figure out what's the best way forward in patient care? Now, there are also multiple guidelines, so which one do you follow? Now, the big ones are the AHA, the American Heart Association, has guidelines on this topic, but so does ASAP, our American College of Emergency Physicians. They have some policy statements with regards to that, and they differ. So let's look at the ACEP policy. Oh, well, there's even guidelines for writing guidelines. And so the Institute of Medicine, again, 10 years ago, put out guidelines for guideline writers. And they said, whenever possible, those developing guidelines shouldn't have conflicts of interest. And certainly the chair or the co-chairs should not be the persons with conflicts of interest. Because sometimes there will be conflicts of interest that may be unavoidable, but it shouldn't be the chair or the co-chair of the guideline writing committee. So here is Brown et al. And this is the guideline from the American College, and it was published in Annals 6 years ago. They didn't give any A recommendation. There was no A recommendations. They gave B recommendations for both the under 3 hours and 3 to 4.5 hours. For the under 3 hour time window, they said TPA should be offered and may be given. And for the 3 to 4.5 hours, it is may be offered and may be given. And then level C recommendations on trying to do shared decision making when doing this. And what were their declared financial conflicts of interest? None. They had no financial conflicts of interest declared. And I'm trying to advance my slide. And of course that happens. Oh, you know why it skipped there? Because this is the big shout out to the NNT. Clearly that's why it skipped slides. I was invited with Morgan Stern from First 10 to redo the NNT review for TPA and acute ischemic stroke this year. And we looked at the evidence and we looked at the 3 systematic reviews that I had mentioned. And based on looking at the data, we downgraded the recommendation from a green light to a yellow light. Again, that's not claiming it doesn't work and not saying we shouldn't use it. It's just claiming that the net benefit and the net harms are unclear due to the uncertainty in the data. And so a yellow light from the NNT. Oh man, it keeps skipping. I will move this over just a tiny bit so that doesn't happen again. All right, so now endovascular therapy for stroke. Lytics are routinely used prior to EVT. And the EVT literature is much more robust than the lytic literature, but it does have some serious limitations like lack of blinding, and blinding is a very important thing. Denominator neglect, which I'll mention. And of course, stopping trials early, which can bias results. So there were a few earlier studies that didn't show benefit for EVT, but then came along Mr. Clean 6 years ago, and it was published in the New England Journal of Medicine, and it was a multi-center randomized, unblinded trial of 500 patients. They found an absolute risk reduction, so a benefit of 14%, which gives a number needed to treat for a good neurologic outcome defined as a modified Rankin score of 0 to 3 at 90 days of 7. So this is what's changed the world when it came to EVT therapy. Here's a table from my good friend over at Rebel EM that shows the different trials, and you can see yellow is, and then green, Mr. Clean hits in 2015. And then a number of other trials that were in process were stopped early because of Mr. Clean. But I'm using this slide to show you how many patients do you have to enroll to find those to include in your study. And if you add them all up, you get about 4.6 patients per center per year. So stroke centers, we're finding about 1 eligible patient for EVT every 3 months. And that gets into the denominator neglect. How many possible stroke patients were screened and a code stroke called to get these impressive NNTs? And some of the trials are as low as an NNT of 2, and then others up to 7, like a single digit. That's impressive. But the agenda is in the numerator and the devil is in the denominator. So let's look at this another way. We're talking about roughly an NNT of 770. That's what I calculated would benefit from EVT. All right, so that's the number I get. Where do I get it? It's just a little over 0.1%. Well, how I get that number is most of the trials didn't tell us how many patients they screened to get patients registered, but one did. That was the Extend IA trial. In this randomized control trial, they screened almost 8,000 patients to register 70. So 8,000, that's a big denominator to get 70. So that's 0.9%, or 1 out of every 110 stroke patients were eligible for EVT. And then the NNT for Mr. Clean, the largest and arguably the most methodologically sound of these trials, was 7 to benefit 1. So that's how I get the NNT of 770. You take 7 and times 110. Patients with a stroke would benefit from this therapy. So the NNT provided by these other randomized control trials, when they say, oh, we got an NNT of 5, they neglect the denominator of how many patients had to be screened to actually get them into the EVT suite and have that clot extracted and then have a good outcome at 90 days. But let's get back to lytics. Lytics are currently used as a bridge for EVT, or facilitated care. Now, many of you, of course, would be too young to know that we used to do facilitated STEMIs. We used to drip and ship. We used to thrombolyse if you were in a non-cath center and then send them to the cath center. Or depending on the time of day, you would push the thrombolytics and they would cath them later. So TPA is given to people in stroke right now who qualify muscle occlusion, the anterior circulation with advanced imaging, showing some salvageable brain. That's the bridge therapy. We're going to give them TPA until we get them the EVT. So what's the evidence on this show? Should we be using TPA in these cases? So a randomized control trial was published last year in the New England Journal of Medicine, and it was a non-inferiority trial. And this non-inferiority trial had just over 650 patients. They were looking at a modified Rankin score at 90 days, and the patient would either get TPA or not get TPA before EVT, and it was within a 4.5-hour window. And what they found was EVT alone was not non-inferior to EVT plus TPA. And so I did a podcast on this, and the conclusion was there doesn't appear to be a role for systemic TPA in acute ischemic stroke for those appropriate patients when EVT is readily available. But we've had 2 other RCTs, both non-inferiority trials, published in JAMA this year, one by Suzuki and one by Z. And the details are listed there. Both were non-inferiority trials, which we can discuss later if you want to get more nerdy. One demonstrated non-inferiority and one didn't demonstrate non-inferiority for EVT plus or minus TPA. But I've got some exciting news for you. You ready for this? It's time to lean in. Oh, exciting news. Yesterday, a systematic review and meta-analysis was published in Neurology. I read it last night. People know that I'm interested in this topic. So of course, a neurologist sent this to me last night after my shift. I'm like, ooh, I've got to incorporate this into the talk. August 24th, 2021, published in Neurology, finger on the pulse of this literature. So it was EVT plus or minus TPA. They pooled those 3 randomized control trials that they have, just over 1,000 patients. The key primary outcome, no statistical difference. No statistical difference for benefit in EVT plus TPA versus EVT no TPA. So the drawbridge came up. Now there was less bleeding if you just did EVT alone. So you don't thrombolyse them. You just do EVT alone, they had less bleeding. But at the end of the day, there was no statistical difference in all-cause mortality. So is it a bridge to somewhere, or is it a drawbridge? We don't have high-quality evidence that TPA should be routinely given before EVT. So I was told I'd have about 20, 25 minutes. So these are the last 2 slides, and then we can get into a discussion. What's the answer? Because I know you want answers, right? Like, what am I supposed to do? I've got to go work a shift either today or tomorrow. What am I going to do? What's the answer to TPA for acute ischemic stroke? And I would say that the answer to that is the answer that my EBM mentor on the left-hand side of the screen gave me. This is Dr. Andrew Worster, and he taught me the answer to almost every question is it all depends. So I would suggest that we take the principles of evidence-based medicine, and that's represented in the Venn diagram you see there on the right, and use those three pillars of evidence-based medicine. The blue circle with the stack of journal articles is the evidence, and the evidence should guide our care, but it's flawed and it's limited and it's never complete. Science is never complete. What we're trying to do is find the quote unquote truth, but when I use the term truth, I'm talking about the closest point estimate of an observed effect size with a confidence interval around that point estimate. And we're always trying to refine that point estimate to get to that proverbial truth. But the literature is flawed on lytics. The literature is limited on lytics. The literature is muddy. So that's the blue circle. But then in the green circle, we have to use our good clinical judgment based on our practice environment. Some of you will work when you graduate in a center that can do EVT. Some of you won't. Some of you will have to ship those patients out if necessary. Some of you will work in a center where you can do centers in community access. I think you call them critical access hospitals, where they do telestroke. And so they don't have a neurologist on site. You have to beam them in. And if you thrombolyse them, you're a long way from a tertiary care center to actually address the known complication of early hemorrhage and bleed. So your clinical judgment, where you work. And then the third pillar of evidence-based medicine is that red circle. Those are the people that actually have the stroke. And we actually have to engage with them. It's really important to broach the subject with them in a transparent manner and talk about the potential benefits, the potential harm, the uncertainty around the data, and ask them what they value and what they prefer. And if they're not able to engage with us because of their medical condition or because of comorbidities, we need to engage with their decision makers, their family. So the last slide, I'm going to leave you with a quote from Dr. John Jackson, and he was a neurologist. And he's quoted as saying, it takes 50 years to get a wrong idea out of medicine and 100 years to get a right idea into medicine. NNTs was published 26 years ago, and we're still talking about it today because it was never replicated. At least that's one of the reasons. And so how long is it going to take us to get the right answer about TPA for acute ischemic stroke? Thank you.
Thank you so much for the wonderful talk. Before we open this to...
this is where somebody else jumps in.
Exactly. Kent, I really want to see your slide on the AHA guidelines, because all the time we get questioned, hey, why are you arguing this? It's in AHA guidelines. Can you go back to that slide?
So I only have the guidelines from ASAP.
Oh, okay. I
did not put up the slide from AHA. The AHA puts out like guidelines after guidelines after guidelines, and there's actually a research study showing the 8,000 recommendations from the AHA over a 10-year period. And out of those 8,000 recommendations that the AHA made, only 10% were level A, and I think 50% were level B, and 40% were level C. And so I didn't put up the AHA guidelines because there's some, well, I think the guidelines or the policy statement from ASAP, without conflicts of interest, they went through very rigorous methodology. I think that those are the guidelines that and policies I'm most aligned with, and had no financial conflicts of interest that as another level of bias. And certainly the AHA guidelines are much stronger in favor of using TPA.
Thank you. I pose a few questions, and then we'll open this to the residents and faculty if you have any questions. The critics of TPA claim that for every one positive TPA trial, as you showed, we have several negative trials, and some trials that have been terminated early because of futility, as you mentioned. Yet most of these trials are not included in systematic reviews that support benefit from TPA. The pro-TPA folks argue that those negative trials were using a streptokinase, which we do not use anymore. You touched on this briefly. Can you expand on your argument on this argument that people say, well, most of the studies that were negative were terminated early for futility, were using a streptokinase, and we shouldn't mention those? Sure.
First of all, I want to say that I'm not pro-TPA, but I'm also not anti-TPA. I'm pro-science. So whatever the science shows is what I will follow. And if someone can give me convincing evidence, I will change my mind. I'll change my opinion. I will change my position. But it's based on science. It's not a pro or con per se. In the table that I gave you of the 13 foundational trials, 3 were stopped early due to harm, not just futility. Only 1 was stopped. Those Atlantis A and Atlantis B. Atlantis A, I believe, was stopped due to futility, and Atlantis B due to harm, but I could have those reversed. And so that gets into how do you address, what you include in systematic reviews and meta-analyses, and those are choices you make. And so if you want to say, and I completely understand the position of saying, well, from a practical standpoint, we're only using alteplase, we're only using TPA, so let's just look at those studies. I tend to be more inclusive, saying, well, unless you have a reason not to include other lytics, then we're ignoring data. We are doing what's called the Texas sharpshooter fallacy. We're only going to include the ones that work and not include the ones that don't work. If you're a baseball fan, you count your hits, but you don't count your misses. And so, of course, you're batting 1,000 if you only do that. And so I would rather be more inclusive. And until there's good evidence that says we should separate those, we have studies of tens of thousands of people from the STEMI literature. And if the pathophysiology is clot, block blood flow, open blood flow, better patient, right? If it's that simple, right? Then the STEMI literature from streptokinase compared to TPA, there wasn't a patient-oriented outcome different in breaking up a clot with regards to their outcome. Now, you're talking about repeat STEMI or mortality, and the brain is different. But until there's some time to say that these agents have differences that are important to a patient outcome, I would say we're ignoring information. And when we have little information, I think it's important to collect as much information as we can. But I certainly understand people saying, well, from a practical standpoint, we're not using it.
So to be clear, is there any head-to-head comparison between streptokinase and TPA for acute ischemic stroke? Something that proves that streptokinase is worse than TPA?
No.
So
but you could argue that streptokinase, because using it, people could be allergic to it, more allergenic. So you could give that. Yeah, you could talk about, what I'm anticipating coming is we're going to see a bunch of non-inferiority studies of TPA versus TNK, like we did in the MI literature, saying, well, it's non-inferior. TNK is non-inferior, but it's easier to use. You just give a single dose. You don't have to run a drip after, right? It's just a single bolus. And so we're going to see these non-inferiority trials coming out with TNK, and they'll have pathophysiologic explanations about the pharmacokinetics or pharmacodynamics about it. But at the end of the day, it'll be a non-inferiority trial saying, hey, it's no worse, but it's easier to give.
Thank you. So given all the arguments and polarization on this topic, what are the obstacles to conducting a large multi-center, multinational trial to put this issue to rest for good? What is the resistance for replicating the trials and doing a big trial? Is that ethical issues? Is there politics? What do you think?
I think it would be multifactorial. I think you'd need to bring in the evidence and methodologic experts to convince an IRB that equipoise exists, because having clinicians come in may be difficult to do that. So I think you need methodologists without skin in the game to say methodologically equipoise exists based on the data available, because to get IRB approval, you need equipoise. But I think given the new technology, I mean, we're basing this on old CT imaging studies, and based on the new imaging technologies, there may or may not be a cohort of patients with small vessel occlusions who do not qualify for EVT, but have a salvageable area of brain that could benefit from TPA. I think that there could be a signal in that noise. And rather than doing a blanket approach and painting with a big brush, it would be great if we could tease out those people that could benefit from those who don't have the potential to benefit and therefore would only have the potential of harm. And that's increased bleeding, symptomatic increased bleeding, and early mortality. And we'd also have to talk to our neurology colleagues to participate in a trial. They'd have to be involved in enrolling these patients. We don't work in isolation. And given the aggressive marketing that you see about all 911 have, I think it's the face sort of thing. If you have a facial droop, there's huge marketing campaigns that have gone to the general public to sensitize them to the urgency to get this treatment. And so it may be difficult to enroll patients because of the large marketing, but I think it comes down to money. There really isn't a financial incentive for a pharmaceutical company to conduct a trial when there is a reasonable likelihood that they will not replicate NNTs or ECAS3. And that would be a self-inflicted wound to their business to do a trial to say, hey, we did it and it didn't work. Okay, I guess we're not marketing this drug anymore. So where is that financial support going to come from? And some people have suggested, well, those people who are skeptical should fund it. Well, that's a little much. We
can all chip in.
Yeah, I'm a multi-billion-dollar multinational pharmaceutical company. I'm just a community doc trying to give great patient care. Whether it comes from a government agency and something like that, I think it's possible. But a trial needs funding, and that it would be highly unlikely that a pharmaceutical company would step in and say, yeah, let's fund this, because there's equipoise, and the result might mean it didn't work and we were wrong. And there's also, I guess, one other thing would be intervention bias. We like to do things, right? I mean, you guys went into emergency medicine because you like to do something. You like procedures, you like immediate gratification. That's part of our profession. Somebody comes in and we diagnose them and we treat them and we make them better. And so there's that huge drive that doing something is better than not doing something. But I think we should also consider the idea of not doing something, just stand there, because we don't have good evidence in this case that doing something, actually in a lot of cases, that doing something is actually better than not doing something. And that's a real hard thing to learn and incorporate into your practice, because there is this, I want to do something, intervention bias.
Especially in field of neurology, that there's really not much to offer to the patients.
Well, and I've heard that, and thank you for saying that. And stroke rehab has actually got really good numbers, with regards to numbers needed to treat. A really good stroke rehab program can have really good benefits. So there is things that can be done. It's just not as immediate, maybe, but yeah, I just, stroke rehab does work. There's good evidence for stroke rehab.
My last question, given that TPA is standard of care, I use that term loosely, given the creation of stroke centers, monitoring door to CT, door to TPA metrics, and etc., seems like the door to further discussion on this topic is being shut in our face. How do we make our voice heard, and how do you suggest we change the course of the uncertainty regarding the TPA for acute stroke?
I think we need to be honest and transparent that we don't have all the answers. When people say the science is settled, I don't think they understand science. And they're not speaking as a scientist, at least from my definition of a scientist, because science is always evolving. It always can have new information. And so to approach this, I would say we all have common ground. Neurology, emergency medicine, physical rehab, patients, we all have common ground. So we want to meet with these individuals with that common ground and start with that common ground and say, we want patients to get the best care based on the best evidence. And so advocating for patient care, I think, is a core part of being a physician. And I'm seeing it more and more in emergency medicine, that we're advocates for our patients. We're there for them. And stroke patients often can't speak for themselves. They don't have a voice. And so I think that we took an ethical and a professional responsibility to speak up and make sure that there's a balanced approach to this. It doesn't mean TPA should not be given. It doesn't mean TPA should never be given. I think it should be offered and may be given, because it's not 100% thing. And when they set up these quality metrics and come and say, 4, 3 is 100, is that what? And I don't think guidelines mean what you think it means. It's sort of a Princess Bride quote, inconceivable, right? I don't think guidelines mean what you think it means. It should guide our care. It shouldn't dictate our care. It's not thou shalt do this and thou shalt not do that. Medicine is nuanced. And that's why I put up that Venn diagram about evidence-based medicine. I think we need to advocate using the evidence-based model and saying, you know, here's the literature. There's very few things in medicine that we have literature on that is so unbelievably powerful and overwhelming and convincing. It's usually nuanced, and there's discussions to have. And it takes place in a clinical environment. And each of our patients is unique and will have different values and preferences. And we shouldn't impose our own values and preferences on those people. As a physician, I've heard physicians say that, you know, well, you know, give me the Hail Mary pass. I'd rather be dead than neurologically damaged. So sure, if there's a chance of improvement with lytics, give it to me. And I've had other people say, no, I don't have that big of a deficit. I don't want to take the chance of having an intracranial hemorrhage. I have a huge life event coming up with children or something like that, and I want to see that through. And I don't want to take the chance of having a symptomatic intracranial hemorrhage or die, even if it's a small chance for that potential improvement in 3 months. So I don't want us to put our own values and preferences on patients. It's really interesting once you start talking to patients. What they value and what they prefer can be very different than what clinicians value and prefer. And without asking them, we don't know.
David, do we have time for questions? Okay. Any questions from any questions regarding this topic?
I have a question. Who is that super cute baby? Oh my goodness. You guys start residency early there. God, another genius coming through your program. I mean, I thought residents looked really young, you know, now I'm in my mid 50s and I see these residents, I'm like, what are you, a teenager? But oh, that is one young resident you got there.
Dr. Allen.
Yeah, question about financial conflict of interest. I guess, can you define what that exactly means? I guess, just like, it seems like our hospital is the EM tends to be more skeptical of TPA. I wonder, does neurology have apparently a financial conflict of interest in that part of their job depends on TPA? just stop or the other?
So the question is, apart from the financial conflict of interest that you described, the association with the pharmaceuticals and other things, is there an inherent conflict of interest for neurologists to have stroke centers? Is there any benefit to them for giving TPA financially versus EM physicians? Did I get that right?
Yeah.
Okay.
So I don't know what individual arrangements have been made with regards to that. So I'll speak in a bigger picture, that if you're creating a stroke center, you're creating jobs. If you're creating a stroke system, you're creating jobs. And for those people that weren't previously treated and doctors weren't on call, there are now a number of positions available to do that. I work in a Canadian system, which is different than the American system, as you may recognize. And so I may not have much insight into the financial arrangements into that, but I can speak to the thing called, there's a cognitive bias called the IKEA bias. So that it's something you build, you make, you're more convinced that it works, that it's wonderful, that it's great. And so it's called the IKEA bias. And you can maybe think of it as sort of recall bias as well, because if you create a stroke center and you spent all this time, money, effort, publicity, marketing, and all of this stuff, you're more likely to remember the wins and the successful stories than you are to remember the misses and the bleeds and the deaths. And so there's also that professional thing that you want to know that you're doing the right thing. Know, people want to do right for their patients, but we do know that it doesn't have to be big dollars. Nudge, right? There's that book Nudge. We can influence people just by giving them a little nudge, and that's why pens with drug logos on it. When you've got medical students coming to a rounds and there's pizza provided by a pharmaceutical company. And once you get to residency, you want to go out and get a nice Thai food restaurant with a drug talk or something. And then when you get up to your staff level, it's like, ooh, we're going to be, going to a conference or something like, so there's different levels with regards to subtle nudging. And I have a number of papers that I could provide on how guidelines have been influenced through nudges. And it's not just a matter of we gave a bunch of money. And I'm certainly not better than anybody else. I'm probably more flawed than anyone else. I mean, when I was asked to do this, I'm like, of course I'll do it. A friend of mine asks me to do it. Of course I'm going to do it, right? I'm going to give this talk. I'm currently up in Northern Ontario, just finished a 60-hour stint covering some rural emergency departments. And I'm like, yeah, no, I'll get up and I'll do this talk. Of course I'm going to do it, because there's that goodwill. And there's a whole arm of marketing and psychology that shows just being nice to someone, right? And nudging them can have an influence. And I'm not better than anybody else. I'm just as flawed. And so that's why I don't take anything. And it's not because I think that my colleagues are corrupt. That's absolutely not true. I just know that I'm just as flawed as them, and I'm easily corruptible. And so I don't take anything, right, to avoid that bias. But I think, to answer your question as best I can, I don't know the financial relationships that American neurologists have in setting up their stroke centers, but I'm sure that there's nudging going on.
Thank you. Jonathan, you had a question? Any other question from remote people?
Can I expand on one other issue just about the systematic reviews?
Please do.
So, people often say, well, how can you look at the same literature and come to different answers? How can these three different groups, and there's more than 3 different systematic reviews on lytics and stroke. And part of it depends on the inclusion and exclusion criteria that the authors use. So you explicitly say, I'm going to include these trials, I'm not going to include those trials based on this rationale. And you either accept that or you don't, as someone who's critically appraising that. But also important is, how good is the ingredients, the included trials? Once they say we're including these trials, how good are they? What are the methodological qualities of those studies? And I like to tell the little story, that's why I wanted to do this. is I grew up on an apple farm. I grew up in the country, rural. So, you know, in this apple farm, my mom made the best apple pies, and that's a hill I'm going to die on. I have no bias to that regard. My mom made the best apple pies, and you know, I'm sorry, this is the hill I'm going to die on. But you know, she used great ingredients: fresh apples, fresh ingredients, you know, cinnamon, brown sugar. Oh, just really, you've got to have some apple pie that my mom makes, right? And so if you have really good apple pie ingredients and try to make a systematic review by the studies that you include, and then you grab some crappy ingredients, some not so good, some unblinded trials are included, or non-randomized trials can be included. But in specifically the TPA literature, if you exclude, or sorry, the TPA trials that were stopped early, those types of things, that adds, you know, those aren't as good ingredients. And so growing up on a farm, if you add poop to a cow pie or to an apple pie, it doesn't make the pie taste any better. You just get a cow pie. And for those of you who didn't grow up in a rural area, a cow poops, and when it poops, it creates this thing on the ground that's about the size of a pie. And so that's how I like to sort of describe looking at systematic reviews. And so, you know, you can have, oh, look, it found down to the 5th decimal point, this point estimate, blah, 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 blah. And it has this illusion of certainty. And you go, yeah, but let's look at the primary literature and how good was it? And so you've got to have high quality ingredients to have high quality systematic reviews. I just wanted to make that point. And I'm happy to take on anybody about pies. You know, anybody they want to bring their
We lost you, Ken.
Oh, okay, sorry.
Oh, no problem.
You good?
Any other questions? Are we done with time? Okay. Well, thank you so much for giving us the talk after your long shift. I really appreciate it. Thank you for contributing to the NNT.com. I'm getting a lot of positive feedbacks from that. I appreciate it. And please come back and give us other talks. I know you're very active in field of evidence-based medicine. We would love to have you back.
I would love to come back, and thank you for the invitation. I do have interests outside of TPA. My interest is actually the science and what does the science say. So I'm happy to talk about other issues other than TPA as it being a one-trick pony. And so I really enjoyed doing this. If I will send you the copy of the slides so people can have all the details, and my contact information is there. Reach out to me anytime. I'm happy to talk or text with anybody.
Thank you so much, and stay safe up there.
Bye, everyone.
Take care.